show us this, we included for the first time as neuro-ophthalmology. You have seen people bear refractive surgeries, pupilloplasties, cataracts, retinas. So let us see how well a neurologist or a neuro-ophthalmologist screws up. Dr. Sengupta is working with CFS in Calcutta, and he is a prolific neuro-ophthalmology consultant there. So whenever Shubhrangshu, you are ready.
So thank you, Dr. Gupta, for including me in this IC. So I'll be speaking on neuroretinal nuisance. So nuisance is essentially a person or a thing which irritates or annoys a person. And whenever I as an ophthalmologist working in a hospital in Kolkata, get any neuro-ophthalmological problem, the first regret is that we don't have a dedicated neuro-ophthalmology unit in our center, and therefore I just depend on two things in my armamentarium. One is referral, and the second is steroids. So let's run through 2 or 3 cases. So first, I have this 19-year-old male who comes with sudden DV in the left eye, 2.5 years ago, and he was seen locally at that point of time and was given some multivitamins which helped in visual recovery to some extent. So the best corrected visual acuity in the right eye when he presented to me was 6/9, left eye was 6/36. There was RAPD, ocular movements were full and free. The fundus, of course, the left-sided optic nerve with pallor was there. So way back in 2013, we had published a paper wherein we had shown retinal nerve fiber layer thickness by OCT3 provides direct assessment of axonal loss in optic neuritis and other neuro-ophthalmic conditions. And since then, we have been documenting the OCT RNFL thickness regularly in neuro-ophthalmic cases. So in this case also, as expected, the left eye showed thinning, but the right eye also had considerable amount of thinning. So now now we got a VEP done. The P100 latencies were increased, as we can see. And therefore, I used the weapon in my armamentarium. I referred the case to a neurologist who did an MRI, found left-sided optic atrophy, but more importantly, there was occlusion of left internal carotid artery. A DSA was done, and here we can see that the left-sided internal carotid artery was actually blocked or stenosed, and there were these vessels from the base of the vascular system which was actually supplying this particular area. So the report came out as occlusion of left supraclinoid internal carotid artery with moya vessels and collateral flow in left hemisphere from left posterior cerebral artery. So now I learned about moya disease. It's a progressive cerebrovascular disorder characterized by stenosis and or occlusion of the carotid artery. Tiny collateral vessels develop to supply the blood. It's a Japanese word which refers to a hazy puff of smoke or cloud. It is commoner in Japanese, Chinese, and it presents either in the 5 to 10-year-olds as stroke or TIAs, and in 30 to 50-year-old bleeds are more common, intracranial bleeds are more common. So it is a nuisance that knowledge can only be acquired by hard work. Sometimes you can get good knowledge by just referring a case. The next case. So this is a 20-year-old male who presented just a couple of months back with foreign body sensation in the left eye. So he also felt that there was some problem when he looked to the left, and the vision was normal, fundus was normal, systemic history was all right. He just had bicuspid aortic valves, that's all. When we did a perimetry, we found bitemporal hemianopia. So obviously we could localize the case, we could localize the lesion to the optic chiasma. And of course I had to refer once again. So this time I referred to a neurosurgeon and an endocrinologist both. The neurosurgeon, he did an MRI and found out a pituitary macroadenoma, and he suggested surgery. Whereas the endocrinologist wanted to go for medical management. The case boomeranged back to me. The patient asks, what do I do now? Do I go for surgery or medical management? Well, I took a deep breath and said, prolactinoma, let's go for medical management. Fortunately, with medical management alone, in a span of 20 days, the field defect started decreasing. The last visit was around 14th May. It was still getting better. So, refer and you shall receive. I'm not talking about cuts or anything, but you shall receive some wisdom so that you can, judge and, guide your cases. Another case, brought by husband and wife dental surgeons to me, is a driver, and he developed sudden right-sided ptosis one day back, and there was a right molar extraction done by them just 4 or 5 days ago, so the situation is a bit jittery now for them. So this guy, 40-year-old, non-diabetic, non-hypertensive, visual acuity was 6/9, color vision normal, mid-dilated, sluggishly reacting pupil, primary exotropy and primary gaze, fundus was normal. So basically the ocular movements, as we can expect in third nerve palsy, other than abduction, all the other movements are more or less restricted. So once again, I had no option but to refer the case to a neurosurgeon. Well, routine bloods were done, they came out normal. CT, MRI, screening MRA was done, and that also came out to be normal. So now the neurologist wanted to repeat MRI in a higher Tesla machine. But what about the cost? Actually, my friends who were the dental surgeons, they were bearing the cost throughout. So once again, the ball was back to my court. And I used the second weapon in my armamentarium, just started on oral steroids, and in a couple of weeks' time, fortunately, he got back his vision, and I'm yet to find out what is the scientific basis. A lot of research I have done. There has been one case reported wherein because of injection during dental extraction, there has been a temporary or transient third nerve palsy, but pupil involving ones, I could not find any case report. So the educated man is a greater nuisance than an uneducated neuro-ophthalmologist like me. And therefore, I step on to my last case. So this is, since this was a neuro-retinal nuisance, so I have presented a case here which is got to do a little bit with the retina as well. So this patient came to me in May for a glaucoma checkup. He had complaints of occasional headache, but there was no visual difficulty according to him, but the vision was 636 part and 660. Routine bloods, etc. were normal. Fundus picture, multiple serous detachment, the left-sided optic nerve head edema was there. DFA showed this classical multiple leaks and subretinal pooling of blood. The OCT was also quite characteristic, these large serous detachment which are septed. So we knew we are dealing with weak age here, though the age is a little less than what we would expect. So this time I was confident that at least now I can do something without referring the case. So I started steroids. Gave him 3 doses of steroid, long tapering course of oral steroids, and the vision did improve in both the eyes. The left side OCT was almost normal during the last visit. So even without referral, as a neuro-ophthalmologist, I could do something, but probably just a couple of days down the line, I received a WhatsApp. I need the sound, please.
Sound?
I received a WhatsApp voice message.
Hello sir, my name is Fardeen Khan. सर मुझे आँख के प्रॉब्लम की वजह से 3 इंजेक्शन लगा था, जिसके वजह से मेरी तबीयत कुछ ख़राब हो गई थी, जैसे पेट में दर्द, बाथरूम में कब्जियत, बदन हाथ में दर्द, ज़्यादातर दोनों कंधों में और पीछे पीठ में, और कमजोरी जैसा लग रहा था, और दोनों हाथ में पीछे पीठ में दाना जैसा हो गया था.
So I had learned my lesson. It is what it is. Pretending it isn't will only do more harm than good. And so once again, I referred the case. Thank you for allowing me to bear my nuisances as a neuro-ophthalmologist.
Excellent bouquet of cases. Any question for Shubhrangshu? Actually, please talk to your dental friends whether they can present in my session next year if possible, because I'll have a session for dental surgeons also daring to bear for ophthalmologist, creating ptosis. Thank you, sir.